Once again, thank you very much for the invitation, and I am really under the real impression of this great futuristic talks. I hope that I could only speak about the same kind of attractive futuristic technology, and I don't want to disappoint you. This is my disclosure. I'm going to talk about something which is clinically extremely relevant for patients with heart failure, and I am going to speak about a device which is available, which is in our hands for the last years, and which has been tested and proven to be very effective in more than 12,000 patients. So we have a lot of data. The only thing we are still missing is a randomized clinical trial, and I'm going to tell you that we are already initiated such trial, and I'm going to summarize where we really stand with these two trials. So let me start by summarizing the extremely timely and complex issue of a functional mitral regurgitation in patients with heart failure, defining this, giving you a little bit of pathophysiology, clinical consequences, and management option in terms of MitraClip. As we all know that there is a differentiation between functional mitral regurgitation and organic mitral regurgitation, and here are definitions. We may debate whether we have a good definition, but the real story about functional mitral regurgitation is that this is not really the disease of the mitral valve apparatus itself, but rather something which is a secondary to LV enlargement and remodeling, as European Society of Cardiology says, or alternatively it can be called ventricular disease leading to abnormality in the function of mitral valve. So this is something which is not primarily focusing on the mitral apparatus itself, which is actually extremely important once we are going to discuss the whole concept of the treatment, because some people are saying that we would fail because this is secondary to a LV dysfunction, but I will discuss this a little bit later. What about epidemiology? We are all dealing with this patient, and we are all aware that it affects many of our patients. These are several studies summarized for you here. So as you see here, obviously everything depends on the clinical characteristics of the patients, about timing of the investigation, about the severity assessment, clinical assessment, etc., etc. But I would say it would be very fair to state that around 25 to 35% of patients with moderate to severe heart failure, they are going to have mitral valve abnormality, functional mitral regurg, as an important comorbidity. So this is extremely common comorbidity affecting a lot of our patients. What about pathophysiology? Again, very briefly, as I already started to discuss, everything starts with a myocardial damage. This is not the primary disease of the mitral valve. This is a secondary disease, being a result of LV remodeling, LV dilation, local remodeling of mitral valve apparatus, leading to functional mitral regurg, which functionally results in volume overload, increased LV wall stress, increased workload, leading to further remodeling, and this vicious circle is going to be closed here. And this statement is very fair, that functional mitral regurg begets to LV remodeling, and LV remodeling begets to functional mitral regurg. So the attractive concept is to somehow cut this vicious circle in order to cut this pathophysiological process and improve the LV remodeling process and heart failure symptoms, and obviously deterioration of the disease. What about clinical consequences? I have selected numerous very well conducted studies. I have only selected two. I have selected I would say, study which are quoted very, very often, showing that This is in patients with ischemic cardiomyopathy, post-MI patients, ischemic mitral regurgitation. Regarding the severity of it, is actually inevitably leading to a bad outcome. And the study, which is separated nearly 10 years from this study in ambulatory heart failure patients, followed by long time, and again gradual increase in mortality, in the bad outcome for those with severe mitral regurgitation. What about the management option? Perhaps it creates the real discussion, the problem here, because as you see here, primary mitral regurg is the derangement and disease of the mitral valve itself. So everybody accepts, and Bless Carabello is a champion in this subject, the surgeon, commenting that correction of primary mitral regurg is actually something we need to do and recommend even at the late stage of the disease. But functional mitral regurgitation is primarily a ventricular problem. So we may not be quite sure whether by correcting this abnormality we really cure the disease itself and we really change the vicious circle of heart failure. But with this new device, with several new devices, we are learning more and more and have more and more evidence that we need to go this way. Just very briefly, to manage optimally functional mitral regurgitation, we obviously need to take into consideration optimal medical treatment. CRT is a very attractive and effective option. Some surgeons are saying that they are able to correct mitral regurg and as a result also prolong life, which is debatable. And I would focus today on percutaneous mitral valve repair, mitral regurgitation correction using the new MitraClip system you have here. Actually, as I said, this is not a futuristic technique. This is a very simple approach based on Ottavio Alfieri concept that if you repair this functional or actually leaking valve, you would improve the natural course of the disease. It started a long time ago, but the device itself, as you see here, was introduced only a decade ago, and over the last 10 years, we already have around 12,000 patients treated with MitraClip worldwide. And perhaps this is one of the most important statements. In clinical practice, vast majority of these patients are not having primary mitral regurgitation, but actually functional mitral regurgitation, being a natural consequence of heart failure. So we have a strong evidence in this population, and I am going to discuss this with you. And also, if you look at the recent years, we will see that there are, can I have one slide back? That we are having a lot of, can I have one slide back, please? So we are having a lot of publications reaching the number of nearly 400, and with a gradual increase over the last 2 or 3 years, including really good studies, including the study which I am going to start my discussion, Everest 2 trial, which was actually the first randomized trial, but randomization was across the very heterogeneous population of patients with moderately severe to moderate to severe mitral regurg, and they tended to be randomized to surgery versus mitral clipping. But if you look carefully at the population, you will see that in this case, minority of these patients, only 27%, tended to have a functional mitral regurgitation, and also ejection fraction was pretty preserved with 60% as a mean in this population. But looking at both the primary efficacy endpoint and then subgroup analysis, you will see that percutaneous repair tended to be comparable with surgical. However, particularly in the group of patients we are discussing, functional one, perhaps this MitraClip may be even more attractive and better option. These are the data which are quite recently published, 4-year follow-up, and again for your perusal, both mitral regurg severity in terms of echo assessment and functional improvement is sustainable, and mitral regurg is durable throughout this 4-year follow-up period. So it stays. Obviously, we may debate whether surgery is better in terms of a durable effect, but in the vast majority of patients who survive this long-term period, it stays and it lasts for several years. Obviously, before we start discussing the patients with functional mitral regurg, I would like to give you the real-world experience. And we have the data. These are the European data in Access EU registry. As you see here, more than 560 patients with significant mitral regurg who underwent mitral clipping at European size. You would say, okay, this is not quite representative because there are 14 highly selected, very experienced centers. And I really agree with this. Because if you see here, implant rate is nearly 100%, 30-day mortality is 3%, and 1-year survival in this sick population is 82%. But this slide shows you that in reality, functional mitral regurgitation actually constitutes majority of these cases. It's not like in this trial, Everest trial, most of them had primary mitral regurg. In clinical practice, those who are most often referred for these procedures, they are heart failure patients. Again, you have here the follow-up of these patients regarding severity of mitral regurg during 12 months follow-up. There is a sustainable effect, and here you have a comparison between baseline versus 6 and 12 months in terms of functional improvement as evidenced by 6 minutes walking test distance. You will see that 50 to 60 meter increase in 6 minutes walking distance is pretty significant improvement, and we always need to consider that there was a sick population. And I'm glad to say that preparing this lecture, I looked into literature and I found a very recent publication from Israel, so I need to congratulate you because you also have already building up the experience. These are the data from this country with 20 patients with significant mitral regurg. Again, I say this reflects the reality. This time, 90% of patients with either functional or mixed mitral regurg, vast majority with impaired ejection fraction, very good results, improvement in mitral regurgitation, and sustainable, durable improvement in functional capacity of these patients. So now let's focus on those who are most challenging, and let's try to address the question whether we have any clear evidence focusing particularly on patients with heart failure. These are the first reports, and Olaf Franzen is the first author here. They focused on 50 heart failure patients with severe functional mitral regurg, with very, very compromised ejection fraction. Ejection fraction in this study is 19%, so very sick people. Optimally pharmacologically managed, with majority having already CRT-ICD, and you will see that the concept in terms of functional but also LV remodeling as a result of mitral clipping is somehow demonstrated here. By implanting mitral clip in these very late stage patients, you are going to reverse remodeling and you are going to improve this patient's functional capacity. But what really matters is the outcome. And perhaps this is the lesson we need to learn and implement for our trials we just initiated in Europe and the United States. If you take those who are really very sick, remember ejection fraction 19%. 6-minute walking test in the vast majority less than 250 meters. very sick people. So if you additionally have those with NIHA class 4, unfortunately, half of those are dead anyway at the end of 1 year follow-up. So perhaps it applies exactly the same way like you already had. Too late is too late. You can't change the natural course of the disease if this is already too late. Anything you can offer is already too late. Here, perhaps in class 3, even if the ventricle is very compromised, the 1 year survival was excellent. In this population, nearly 96%, so really excellent. Another question, which was subsequently asked, what about those who are non-responders to CRT? They still have a functional mitral regurg, and they are not responding to this conventional treatment in a predictable way. Very nice survey, this time led by Angela Auricchio from Italy, our good friend, PEMIT care survey, showing that again, over the 12 months follow-up in these very sick people with heart failure, implantation of mitral clip is changing their symptoms, but pathophysiologically, even more importantly, we are able in this sick group reverse remodeling, which is evidence on this part of the graph. You are decreasing the size of LV and perhaps also changing the natural history of the disease. So if we summarize this, we have several studies, registries. We have few, if not the only one, average 2 randomized clinical trial. We still need more and more data, and this is why in the guidelines we still are a little bit hesitant what to say. For the European Society of Cardiology guidelines, we really need to have a firm, clear evidence, and this is why 2 years ago, once we wrote the guidelines, we said that in patients with an indication for valve repair but judged inoperable, this mitral clip is a very promising option and may well be considered. But at the same time, we decided to initiate in Europe, and our colleagues in America did more or less the same, randomized clinical trial in order to answer the question whether this therapy in a bigger population is able to change the outcome of patients with chronic heart failure. So this reshaped trial set up the following objectives. We wish to study safety and effectiveness of the mitral clip system in patients with class 3 and 4 chronic heart failure patients. We wish to demonstrate and provide evidence necessary to recommend this therapy based on this trial, and obviously we are going to evaluate cost effectiveness of this therapy. The design of the trial is fairly simple. We are going to investigate patients with mitral severe, moderate to severe mitral regurg and heart failure, functional mitral regurgitation. These patients are going to be randomized 1-to-1 into device and control group. They are going to be closely monitored and followed at least for 1 year, and the primary endpoint of this trial is actually combined endpoint of all-cause mortality and recurrent heart failure hospitalization. The same trial is actually running, or similar trial is running in America with slightly less number of patients. The reason for less patients is that they have a slightly different primary endpoint. Now we are reconsidering whether we should not also have a slightly different design and change a little bit the design of the trial. However, we agree with our American colleagues that perhaps rehospitalization during 1 year follow-up should be, or recurrent rehospitalization should be the leading endpoint, and death should be added as a secondary endpoint. Both trials have been initiated, and we are waiting for the results before we can answer the question whether the future of mitral regurg with mitral clip is going to be recommended in the guidelines. Thank you for your attention.
Presentation. We are short of time, but as a surgeon, allow me just to add one very brief comment. We have no argument whatsoever that the patients who are indeed totally inoperable or very extremely high risk patients for surgery, the MitraClip is indicated even in fractional and severe fractional mitral regurgitation. However, you have mentioned, and we are in the field where we start hearing about considering patients who are not in extremity of heart failure due to severe mitral regurgitation, to consider patients who are in somewhat lower degree of heart failure. And I want to urge everybody in the audience and to be aware of the recent result of a study that came out of the Mayo Clinic in the United States and several other centers who compared mitral repair to surgical mitral valve replacement in extreme ischemic heart disease. And the results of mitral repair, surgical repair, were extremely lower compared to the mitral valve replacement. So time is not right yet to consider patients who are inoperable. Those who are really operable, definitely it's a good solution for them, but let's not haste our way and consider them for patients who are still in surgical care.
Can I only comment?
Absolutely.
I learned from the past that the worst case scenario is to disagree with the host. I don't want to disagree with the host, and the second conflict of interest I need to declare is I always wanted to be cardiac surgeon and failed. But if we look at the paper you are quoting, I am going to say that actually this is not the paper about mortality, because if you read the paper in New England very carefully, the endpoint of the trial was mainly based on LV remodeling. So it was not really mortality paper. If we are going to discuss the results of this study, which was not quite what we are doing, we can only say that LV shape-wise and LV remodeling-wise, we can debate what is better. On the other hand, you perhaps also agree that admiring this cardiac surgery world, you don't have any trial to convincingly demonstrate that if you are focusing on patients for whom you only operating on the mitral valve without cabbage, you can achieve anything. Obviously, if I am talking to my cardiac surgeons, they are truly convinced that they improve everything. But if you look in the literature, and if worst come to the worst, it is debatable.